Yeah, my full disclosure. I think that we are always convinced that intracoronary images are an important component of invasive procedure for two aspects. One is to make a diagnosis, for the other ones, for the real-time PCI guidance. Here you have where we are today in terms of high-quality imaging. And you may see that we have an incredible quality of images. You have here the same patient in a different setting, could be bifurcation, could be aneurysm in the central panel. I don't know who is touching this. Could be calcification at this level. And you have exactly the sister images, the ones obtained with IVUS and the ones obtained with OCT. And you can see anyway that we got a lot of information already. So high resolution is extremely important. But high resolution is bringing some burden imposed by imaging to the operator. Which one? Most interpretation is still visually performed. It's subjective. It's due to the experience, to the time available, to the time on the day, means the operator fatigue. The higher the density of the images, the higher is the number of the pixel resolution. That is, you have a massive data to be managed, what we call gigapixel. While we still have a very few quantification and numbers that instead needed to be available for making the correct measurements, and they could be automatically done instead of that manually done. And finally, one of the big limits is that we are keeping with us with imaging. We are not writing a report. We are not embedding clinical notes. We are not sending to our colleagues in the world. Since when we started, we were focused on this fascinating imaging in cross-sectional view, where you have an incredible details. After some years, we moved to the longitudinal view because it's mimicking what we are doing with the angio. But from this pristine imaging, we learn that we can get numbers. And the numbers can be obtained automatically. And that is going to be very important for making judgment. What the deep learning in cardiovascular imaging is going to bring? Number one, is going to impact all type of images. Not only the cath lab is going to impact CT, is going to impact maybe left ventricular function, echo, with two essential goals. The first one is a short term. We wanted to provide a more objective and faster imaging quantification, so saving time. The second one is long term, new insight into the complex relationship with the decision making. For doing this, we need a very high quality images. Here you have the spectrum of all the different specialties and the weight, the interest in developing new AE software in support of the clinical practice. And you might see here that among all the specialty tools, radiology and cardiology seems to lead the interest to have AI brought to the clinical activity. What about the coming of AI into the cath lab? Well, could be massive, could be pre-intervention, with all these possibilities of integration, could be during intervention, could be post-intervention. So it's not only strictly linked to the pure imaging. In which area we can improve by using AI in support to imaging? Detection of the pathology, quantification of the disease, characterization of the disease, means low risk versus high risk, decision-making during the procedure, and a little bit forgot, but extremely important in the future, 3D dimension that is going to play one major role. Let's start to explain to the people. They say that I don't know what to do with so much information, what can be done by using AI. Detection of the pathology findings. Why we went first to the calcium? Because the calcium is everywhere. And we are seeing the more and more every day the calcium exploding at all levels, from the periphery to the coronary artery, at the level of the valve. So calcium, and why calcium is so important for imaging? Because angio is not very effective in detecting. Because calcium, if you are age 70, is almost present in at least one plaque of every person. Because intravascular imaging has a very high sensitivity in detecting calcium, because we know that calcium is creating problems, especially to the stents, and because we have something new coming that can allow the treatment of the calcification. This slide was already present. When you compare calcium, fibrotic, and other plaque, you can see the vast majority of the changes in strategy when you know the calcium is, vast majority in the device changes is in this plaque, where you have a calcification. Here you have one example of what can be done today. Today, by using artificial intelligence, as soon as you finish the pullback, that means 2.5 seconds, you don't have only the measurements of the lumen automatically done, but you have automatically the measure of each section in terms of calcium, that is in orange. So you know about the arc of the circumference. With a arrowhead, we know about the thickness. And if you are moving just a few sections after, can you see that the value are changing? When you are going in a section where apparently there is no the orange outside, it does not mean that you don't have a calcium, but the calcium is limited. And this is what we would like to be informed when calcium is not present or when is irrelevant for going ahead. But in addition, you have the display on your angiography. So you know immediately by graphically display where the calcium is, and you have all of this data with the co-registration. They allow to you to localize the intervention. Here you have one of the important reasons why we are interested to the detection of the calcium and to the treatment, because we have new entries coming with us. So this is lithotripsy. This is another lithotripsy that we presented at Innovation PCR that is using different technology and microfibers. And perhaps we will face new technology in the future, not only for cracking, but also for molding the calcified plaque. A might have additional value in intervention. The first one, it can be very reliable in making automatic analysis. In the past, we got the lumen, automatic lumen border. Now we are going to get something different, that is the EL. Here you might see the same patients. Here in the center, you have each section. When you cannot see the EL because you have a plaque around, you have only the value of the lumen and the lumen area. When you are moving to segment similar to this, where there is no EL, you will never have any additional number. But then A can give you the additional number automatically done, expressed by this tiny white line, when you have enough EL to be measured. And you can immediately go and compare the lumen and the EL, because the two measurements are important. The EL is the extreme value that eventually you can reach. And you might have automatically done exactly at the end of the pullback. What is the capability in detecting? Very high. Here you have the algorithm confronted to the expert annotated area. You can see if the quality of data is good, you can be good. While we needed to use, in this case, AVL can be benefit, this nasty vessel, diffuse disease, where it's very difficult to detect the EL. And this is the projection. So we are stopping. Almost all the lumen is without the white line because it is diffuse disease. You are going distally, and here you started to have the measurements. And sometimes it's important to stop in the midway because you can be oriented about the change in size. You don't need many frames, but you need some frames that you can do measurements when you have this sort of diffuse disease. But calcification is not existing per se. Calcification many times is presenting with acute coronary syndrome. This is one of the last paper released by multiple authors, and you can see how much is the lack of the evidence that we still have when we have a patient presented with a calcification and acute coronary syndrome. So huge amount to do that OCT can help us in depicting. This is the case that I'm not sure is working. I think that there are some problems. It doesn't matter. Is the patient before with a severe calcified lesion, as you might see in the first part of the LAD, presenting with a ST segment elevation and depression in AVR and depression in all the precordial leads. And so in this very severe calcification, the great is not only to detect calcium, but the great is to detect together calcium with a layer plaque, the history of this patient, and with a multi-channel thrombus. So you have all the parameters they are guiding this patient. And if you are treating, you wanted to know the effect of the treatment. This is exactly the same patient after the treatment. You wanted to see the incision, you wanted to see the crack, the dissection, when you prepare the lesion. This is in the same patient, one additional value of AI. What is bringing? The possibility to compare. What to compare? The original lumen, so is called segmentation or co-registration alignment, the original lumen with what you achieve. Here is the first part of the stent, here is the distal part of the stent. What about the future after calcium lipid? Because we must need information about the lipid. Where we are, is it so far away, is not so far away. And we are working with one intention, to be able to detect not only the plaque, but to assess the patient and try to get all this information for dividing low versus high risk profile, and eventually to identify quickly the high risk plaque profile. Here you have another example, how AI can help in characterization of the pathology. We saw some example of erosion that is becoming an important reality, but we know that to have the diagnosis of erosion many times by OCT is challenging. And what we are doing normally in the clinical practice, we are moving back and forth with the frame. We are not staying with the frame. We are feeding the AI in the same way. Instead to provide a deep learning on single frame, we are providing the frame that we think plus the neighboring frame, to be more precise in detecting. The intention is eventually, if we can, stratify the risk of the coronary lesion. So if you have a younger patient, female, in the premenopausal time, coming with a chest pain, we know that probably she has more chance to have an eroding plaque compared to another patient that have a different characteristic, mixing clinical value with imaging. This is one of the last example to show how much we can use this technology also for fusing information and to try to get a different type of a significant of the lesion. Challenges of AI first. Don't trust completely to the AI. You cannot say de-skilling is not my role, I'm leaving to the AI to decide. You need to control. Second, sharing data. Data are very important. There are no hundreds, there are thousands and thousands. So we have problems with the privacy and cybersecurity. And then normally, the disease in medicine has a longer tail, so we need to have all the cases represented. In conclusion, while greater resolution is beneficial to imaging guidance, the application of AI to current imaging is a more robust approach, but it remains largely unexplored. Artificial intelligence algorithms have shown impressive results in time-consuming imaging interpretation and segmentation. They are saving time. AI provides more objectives and faster imaging labeling and quantification. We saw the example of calcium detection, plaque classification, automatic out-of-border, the famous EL. The implementation of AI in predictive medicine is a far more attractive prospect, but requires time and validation through our large database, and that is only a community effort. Thank you very much.